Dr. Bernard Okoe Boye, you have also been, I'm not sure you've run a hospital before, but you are a doctor, which means you've taken care of issues like, minister, I keep forgetting that one. You were in charge of policy, you were, so it's a policy failure what we are seeing now, isn't it?
Well, first of all, let me say a very good morning to your viewers and to my colleagues and friends who are here. I think usually what you hear is that there's no bed, and they say no bed syndrome, but it's just a symptom of many factors. You know, it's a product of many things coming together. And I'll start by first of all appreciating the hard work of most of these medical personnel. You know, like they say in journalism, it is bad news that sells. Most of these workers are running around the clock 24 hours, saving lives. And when they save 1,000 lives at Reach Hospital, it is no news. It is that one person that maybe experiences an unfortunate event that goes to the whole country. So I always start by acknowledging them because I have a feel of what life is in the hospital. I was in Chebi like somewhere 2013. I was working in Chebi, the government hospital. There were occasions where I was the facility manager, you know. So I also have an idea of some of the challenges you face at top level. Let me start by saying that in 2018, I have the report I was going through. There was a no-bed case where a 75-year-old man also went to about 7 hospitals, all said no bed. Yeah. And when they did the committee, the work, they found out that some actually had beds. It's interesting. The private hospital they went to, C&J, had bed both at the emergency and in the wards. But some of the public hospitals they went to had no beds at the emergency, but had beds inside, in the wards. Now, so the hospital is like a factory. When you are coming into the hospital, the entry is the emergency. But when you are stabilized or handled, when your life, you are stable now, you have to move inside. Sometimes people stay too long at the entry point, whilst there are beds that can receive them. And so monitoring and some level of effective supervision helps to keep the conveyor moving. So that you always create bed. That's
so that the 24-hour thing
can work. The reason why sometimes some patients keep a little bit longer at the emergency, and even the medical personnel are hesitant to move them into the wards, is that some of the machines you need for a high dependency unit person. High dependency means that the fellow is in a situation where you have to monitor a lot of things. You don't have some of those gadgets in the ward. You know, our wards normally are like lines where they can check your pressure and all that. But to have a machine on you, checking your pulse, your heart rate and everything continuously, sometimes you have it at the emergency and not on the ward. So the doctor is a little bit anxious that when he takes you to the ward, that level of care drops. So they prefer to keep you a little bit until you are stable. And by keeping you a little bit, you are blocking the new entrance. So these are some of the challenges that the doctors face.
But we have ICU, is that
not? So you see, most of the time, the ICU facility is similar to what you experience at the emergency unit. And for some strange reasons, most of the ICUs, you can have an inpatient in the hospital who is at the ICU being handled, a complication from surgery. So you, the outsider, it is even difficult to access. And for some strange reasons, I'll come to the medium to long-term designs. Our hospitals are designed such that there are so many beds in the wards, but few at the emergency and the ICU. So even in terms of structural design, we must start to look at a few things. You can do that in the districts, but where population density is high, you have to look at the design. So that the bedding, so when you go, the physical space is a challenge when you have to pass through the entry point, the emergency. Look, Accra's population keeps on growing. I was just checking some documents with the WHO. For every population, for every 1,000 people, you should have 5 emergency beds. Lekma, Lejikuku alone, is a population of close to 300,000. If you divide by 5,000, the figure is, I'm sure it's way beyond 30 or 40.
So every 1,000 should have
5 emergency beds per population. That's the standard.
Okay.
If you can't even do 5, do 3. But if you come to Lekma with a population of about 300,000, and they don't only receive cases in Lejikuku, it comes from Krowala and all that. They have just about 10 to 12 beds at the emergency. So if 5, in fact, the main place is actually 5, and they have some 2 wards which can absorb people from the 5. So 4 with about 12 beds. Can you imagine tertiary crawl wall, spin test, all it's 4 or 5 beds.
Even Sakumono.
Sakumono. So within a short time, the place is full. Meanwhile, when you go into the hospital, they have wards. Someone say, why don't you move them? When they move them there, the infrastructure in the ward is not safe like at the emergency. Okay. So that is one problem. Now, when you move them from Lekma, there's no bed, and you try to move them to, let's say, police hospital. Police hospital is also choked. So in terms of physical beds, we need to add some more bed space. Either we expand just the emergency as a quick measure. We can get an architect. We tried to do it when I was in Cape Coast. They still have a plan. When I was at the ministry, we were trying to help Cape Coast just at the emergency to expand. I wanted to do that with Lekma Hospital too, but the Chinese who actually built Lekma had plans to try and expand the hospital. So they said, instead of we going for this short track, we should take our time. So physical beds is a problem. The next thing which becomes a problem is equipment. So I'll give you an example. They rush you to, let's say, Mamobi Polyclinic. You have a fracture. You've been hit by a motorbike, or you're on a motor, you're falling. They realize they have multiple fractures. They have a bed. They can give you painkillers, but they realize they don't have an X-ray, or their X-ray machine is not working. If they don't take an X-ray to have an idea of the injury you have, they can't continue managing you. So after more or less splinting your leg, giving you some painkillers, they want you to move to Ridge, where the X-ray machine is working. So you moved only because of equipment, not bed space. And then when you get to Ridge, here you are in the queue. Their places are choked. Yet, if Mamobi had equipment, X-ray equipment, you would have been dealt with at Mamobi.
So it's not just a no bed issue, it's a no infrastructure issue.
Yes. So equipment is one. Sometimes the fellow is rushed there. They have an abdominal problem. The doctor is thinking of acute appendicitis. They can operate, but maybe they don't have a scan or some other machine, or they don't even have blood. Their place is that their blood bank is not that massive. So they'll say, look, you are safer at Ridge, because if I take you in and I need blood, you can be in trouble. So you've moved because in terms of their infrastructure, their blood space is a problem. So people move not because of physical space, but equipment.
But can they reject the person with the abdominal thing at the Mamprobi Polyclinic? Should they? Are they allowed? Because
I'll come there in terms of, I'm just touching on some of the things. These are some of the causes, and then the things that we can do. It doesn't mean that we can't do anything. There are a few things that we also can improve. The third one, which is a major one, has to do with the staffing in terms of numbers and the specialization. So you are a cancer patient being seen at Korle Bu, and then one night you get a complication and they rush you to, let's say, Lekma Hospital. You are a known cancer patient at Korle Bu. They check and realize that you have issue with blood. Your blood has gone down. They will quickly maybe transfuse you 1 or 2. But beyond that, they are handicapped. You need to see the oncologist at Korle Bu. They don't have an oncologist. So they would be trying to move you to Korle Bu, where you can have a more detailed plan. But in such a case, you shouldn't be turned away. They should at least intervene. So these are some of the 3 or 4, and I think the last major one, I spoke to about 3 or 4 medical health of facilities in Accra. So some of the factors I'm giving you are real life factors. One told me that, doc, health financing is key, and I've thought of that. You know what is happening? They rush an accident victim to Focus. Focus has the best specialists. They can do everything for you. But you know what Focus will say? I'm not saying that's what they say. I'm just giving the amount. Put in some deposits.
Because they are private.
Yes, put in some deposits. Maybe the deposit is 50K, 50,000. If nobody can raise that money for you, Focus would like you to go to Ridge, because Ridge is government. Their cost is likely to be down, and should you become a bad debt, some way, somehow, they will find a way to absorb through government. And
so it's a business thing. Finance issue.
Yes, and you see, the 70% of the costs of hospitals going into debts or closing down is bad debt from the emergency. Emergency is one of the places where you can build debts and go under if you don't get any bailout. So Focus to say put a deposit. So you see the ambulance now coming to Ridge. Now, if you go to a bank hospital, they have one of the finest infrastructure. In fact, bank hospitals infrastructure can compare to any hospital in the US and anywhere. But bank hospital might say that deposit 50K.
Even though they are government? You
see, bank was built by government. But in terms of their financing model and operations, they must raise money to take care of their running, administration, and inputs and consumables and all that. Now, so people go to bank, they'll tell them deposit. Some, guess what? Some find the money for 24 hours. And then when they look at the cost involved, they say, you know what, move me to police hospital. So you have referral, not because they don't have the expertise and infrastructure, but financing.
Okay.
So going forward, I've always, we tried to discuss with insurance. It wasn't going anywhere. We pay motor insurance as soon as possible. Some percentage, if not for motor, from somewhere, must go into a particular trust. It can be a wing of the Ghana Medical Trust Fund, Mama case, or health insurance, where any case that is an emergency case can be handled at any private hospital. But for, let's say, a number of days, you don't want to make it unlimited, otherwise you can go into. So let's say 5 days. When the 5 days expires, they should write a report of releasing you either to another hospital, to a government hospital. At least we are saying that if your life could have been saved, that 5 days is enough to take you out of trouble. Because if it turns into 1 month, 6 months, then it's becoming a chronic case. This health financing is key. Guess what? University of Ghana Medical Center, one of the best hospitals in Ghana. If you are taken there and you don't make a deposit, they might move you to RIDGE. So people are rushing to RIDGE because RIDGE is so-called government. And RIDGE is helpless. Even if there are 1,000, they must be in a queue. Whereas you go to University of Ghana Medical Center with the best trauma surgeons, the place is quiet because of financing. Bank hospital, financing. Nyaho, financing. So the law should make it that any hospital, whether private or public, should take you. And then you write a report to an agency that will pay for 5 days. And then we can get something.
But over the period, maybe they've tried it and the financing was...
It's not been tried. We've never had a policy where emergencies are taken and you go to a place for your money. Normally, the Ghana Service will issue a directive, don't turn away the patient. But when you keep the patient and you run your consumables and you are into debt, you don't know who is coming to pay. You know, so this is a very critical matter. And like I said, most hospitals suffer. Only one patient can run your finances down.
So your solution is that put bank hospital, UGMC, all those hospitals...
They must accept emergencies.
Put them onto the...
Yes, but you must create the financing unit.
So they must accept emergencies without deposits.
Without deposits for a number of days, and then after those days expire, they write a report asking for their money and telling what happened to the patient. Whether they send the patient home, a patient might still need care, emergency care for 5 days.
I'll come back to you, but your colleague is disagreeing.
You see, we can't beg Legon to take patients on a separate policy. The policy guidelines for emergency says if a patient is presented to the emergency triage,
regardless of which hospital,
regardless whether it's Legon,
but it's a private
no, please. This is a policy by government.
I agree, Doc. I'm coming there with you.
Let's not beg them.
No, I'm not begging. Let me just address that. With all due respect, I even wrote it here. There must be training. Okay. It's one of the things we also have. You know, we have, for every problem, you have the immediate ones, which you can do. Training is one of them. Yeah. You have the medium term, in terms of adding physical bed space, building and all that. And then you have the long term, in terms of policy and all that. I know of the guidelines that says that charge. And that one, it is not subject to compromise. So I agree with you. Now, a patient comes, you've charged. I've checked you and I've realized that you actually need blood transfusion. I have to intervene, but I don't have the blood. After charging you, I know what to do for you. If I don't have blood in stock and I take you to theater and I operate and you die from hypovolemic shock for low blood, nobody will forgive me for saying that if I moved you away, maybe you suffer more struggles.
Go for the blood.
You understand?
So it's better I transfer you.
Yeah, so it's better I communicate with another facility, either to bring the blood.
Bring the blood.
I'm coming. Either to bring the blood or you go for the blood. Sometimes I'm taking you to theater, but I don't have an anesthetic. I have only one anesthetic lady who is pregnant, is not available. I can't operate you without the anesthetic. Okay, so the point I'm making is that the training is important to ensure that you intervene, and the physical intervention is key. With Ridge's case, because of medical legal matter, I'm not going. But sometimes they intervened without a physical intervention, and I explain. Medical staff went in, checked on the patient, looked at oxygen concentration, realized that this patient needs oxygen once you bring out, only to have a situation where all their oxygen outlets were being received by another citizen. You can't say that, let me take the oxygen from Umaru and give it to Doc for some time. So their suggestion was that we've communicated with another facility. They have an outflow. So move the patient. But the mistake is that if those watching, both relatives, all that you've done, they have no idea what you've done. But if you are even going in with setting another line, like a physical intervention, like I call it, do something, put in a few things and write, then you know that, oh, Ridge didn't just send us away. They did an intervention. So the training is important. And
Question: the ambulance truck
Yeah.
with everything in there, is that not a moving hospital?
Yeah,
No.
so
can the doctors, if they don't have the bed,
Yeah.
can they not
look,
enter the
that's
ambulance?
why I said it's already happening. Our doctors and medical staff are doing their best. Sometimes they give a treatment plan for the patient in the ambulance for about an hour or two. When now they move someone to the ward, then they bring the patient to the space. All this is happening. They are doing their best to make sure that they save lives.
In this particular case, it did not happen.
That's why I'm saying that in this case, they did the assessment in the ambulance and realized that the oxygen saturation for the patient was low. This patient you don't just bring the patient to the bed, but must receive oxygen. With the others having oxygen, and the ambulance was actually having an oxygen concentration. I think they think the flow was not sufficient. Theirs would be better, but others were on. And after 15 minutes of assessment and negotiation, they were like, look, after all this, they would better be placed if they continue receiving and this is not to give an excuse. I'm just giving you what is happening. If they continue with the ambulance oxygen and get a better flow oxygen at the next facility. But what would have made things better is that the relatives and family would have been happier if there's fiscal intervention. Two ways: either you go in there, set a line, give an IV fluid, give some chest, how do you call it, a dilator, something that would aid the situation before writing a report that we are moving on the care to another place. So the optics is important. That's why training is good, because a young doctor who is looking at only the management plan will tell you that these are the 3 steps I have to take. I've done that. Meanwhile, myself with my experience knows that without a fiscal intervention, you are in trouble with patients. And I'll end with one example at Chebi, where a patient came very bad and virtually brought in almost dead. And I asked one of the nurses that, go and set a line. He said, doc, this patient will not benefit from a line. I said, you set a line and put a fluid. You see what will happen. This patient died. Within 3-4 days, the whole family came to the ward to come and give them foodstuffs and to thank them. Why?
Wow.
Because they made an effort to save their patient. And that they knew, they said they knew the patient was in a very bad state. But if they had not done that,
if you have rejected the
yes,
patient,
we were in trouble. So it is training to manage both the medical plan and the public perception plan.
Okay.
Our doctors are doing their best, but we can improve.
Okay.
Monitoring, supervision. We should also have a committee. Every case of death from pregnancy related issues, we hold meetings in the hospital on them. When any woman who is pregnant dies, there is a whole meeting involving management in every hospital in Ghana.
Really?
It's a policy. Yes, they call it maternal audit, to find out what went wrong. It can be a problem with the one who should have operated, a problem with the receiving nurse. We doctors do it. Doc was doing it when he was in service. We should bring that attitude towards emergencies. Any death that happens in emergencies, even when it doesn't come to the national level, or even in the hospital, if you lose a patient for an emergency, there must be an audit to show whether we could have done something. For now, the practice has been that if you die, it is your time. But that cannot be the case. So,
and it's not just because they want to take a box. They actually do this meeting in the audit
yes,
you're talking about.
For maternal cases, we do it to identify what made the woman die. And for some strange reason, even if it looks natural, we always try to put it somewhere so that we can improve that place.
If it happens in maternity, it doesn't happen anywhere else. Does it happen in surgical?
The level of attention that one gets is not the same level that others get.
Is it because someone is paying for that to be happening, or someone says that should happen?
I think it's because over the years, studies have shown that with improvement in every corner, we can reduce the number of women that die through pregnancy-related issues.
Okay.
And we've convinced ourselves that no matter what happens, it is human-related.
Very well.
So we can improve.
Okay.
And I think we can do that with emergencies.
Okay. Andrew, I'll come to you to look at the legal side of things for me, but I